move on to the next talk, I would like to invite Dr. Gaurav Luthra, sir. Dr. Gaurav Luthra sir is the director of Drishti Eye Institute from Dehradun, and he's a prolific cataract and refractive surgeon. We are lucky to have you with us here today, sir. Dr. Gaurav will be discussing the IOL formulae and their details, which formulae to use and when to use them. I'd also like to mention that I'm required to say any commercial names of medical devices, software or equipment may appear in this content because they're linked to specific medical procedures which are the focus of this training material. Other products on the market can be used to perform the aforementioned medical procedures. The educational provider does not endorse any particular product. Thank you.
Thanks, Sophia, and a very good afternoon to everyone. And I'm lucky to be in Sri Ganesh's course for the last couple of years. And excellent talk by Shreyas on various new devices, and they keep getting better every year. And so do our formulas for IOL calculation. We keep learning new things each passing year. So it's really evolved. We've seen this evolve. I started doing cataract surgery somewhere in 1992, and then we've seen how this has evolved. The first generation formulas. I remember, memorizing one of the formulas, which was the SRK formula, and then that's when I came in. And after that, we've actually grown the third generation formulas, the Hoffer Q, the SRKT, which again still remains very relevant. Then the fourth generation formulas like the Olsen and the Haggis and the Holiday 2. And then of course these newer formulas, and then yet still we have more things coming up like the ray tracing and others. So this is how it stacks up. And this chart keeps getting bigger and bigger with every passing year. As you can see, the shorter eyes, the normal eyes and the longer eyes. And on the right, you'll see that these formulas from here till here are those which are for the normal anterior segment anatomy, and the lower ones are going to be able to cope with all the types of anterior segment types, which means shallow ACs and deep chambers and long eyes and short eyes. Similarly, on the left, you'll see that these are the Virgin's formulas right up till Holiday 2. Olsen C is a ray tracing formula, and then the Barrett's and the Hill RBF, which have become really our mainstay, and we hardly ever go to the other formulas now in our practice. We stick to the Barrett's, which works from the shortest to the longest eyes, and the Hill RBF, which seems to have even a bigger, the Hill RBF 3 has gone, for these unusual eyes, it has gone beyond even the Barrett's maybe. So if we look back at SRKT, which as I said still remains relevant sometimes when you're doing ultrasonic biometry, when optical biometry is not possible, it tends to still give us a great result, and it predicts the ELP using the axial length and the corneal power. And this can be used, should be used for eyes which are longer than 26 mm even today. And whereas, for the regular eyes between 22 and 24 millimeters, you can use the Hoffer Q, the Holiday 1 and SRKT as well. So the SRK 1 and 2 are now obsolete and should no longer be used. The Hoffer Q is basically, we've all used it for shorter eyes, and it basically gives you a personalized ACDs developed from any given series of particular IOL styles, and then this is used, the axial length and the corneal power is used to predict. Now this is it still stands the test of time for eyes which are shorter than 22 millimeters, although now Barrett's and the Hill RBF have become really good with the shorter eyes as well. The Holiday 2 again takes into account several parameters. So 7 parameters are used for predicting the surgeon factor, and these are all the factors which can be used. And it is again recommended from the short to the long eyes, and using the Wong-Cock adjustment, it has been shown that it can be used even from the short to the longest eyes with the meniscal IOL designs. So that WK adjustment really helps increase the range of these formulas. The Olsen C came out many years back, and this was came out with a lot of promise with the ray tracing constant or C constant, which it was using to predict the ELP. And this was popular in the beginning. I don't use it anymore, and it's still used by a lot of surgeons. I in fact had the opportunity to work with Hill RBF formula with Warren Hill, and we were providing him data of the Indian database with the artificial intelligence. So basically the Hill RBF started off as the first formula which was using artificial intelligence. The Hill RBF2 came up in 2018 with a bigger database, and essentially it was trying to tell you about the eyes which are falling into the normal group. So it dramatically increase the range from the short and the long eyes up to 40 diopters and up till -5 diopters. and they increased the number of eyes database which was used for creating these deep learning models from to just about 12,419. So this included a lot of short axial length and long axial length eyes. So essentially this formula tends to, it's not a formula, it's basically a deep learning algorithm, and it tells you whether what kind of ILPAR it is predicting based on the database, and then it'll also tell you whether the prediction which it is giving is within bounds or out of bounds. So those eyes which are within bounds are essentially those where it tells that the accuracy is great, and where it says that it's out of bounds, it will still give you a par, but it may not be as predictable as it is with the eyes which are within bounds. So you can also aim for residual errors. So if you want to aim for a myopia of say -1 or -2 or a +1, you can feed that into it and it will still give you a very good par calculation. And it comes integrated with the Abulafia Koch toric calculator, just like the Barrett's toric. They are about the same, so there's no big difference on the toric calculation between the two. So the Hill RBF is actually built into the Lenstar. It's a Harkstrite proprietary thing which has a kind of a monopoly, but then the Hill RBF is also available as a free calculator online, and anybody can use it with optical biometry. So it comes by rbfcalculator.com. I think that's the site which is used. So this actually Hill RBF evolved to the version 3 sometime back, and there again the range was further increased, and it was also taking into account the meniscus designs till the -5. And now it also took into account 8 variables. When it started off, it was taking into account only 3 or 4 variables, but now to have more out of bound cases fall into bounds, they actually have included more variables. So you can use lens thickness, the white to white, and the central corneal thickness, and even the gender, for giving even better deep learning artificial intelligence based calculations, and this has really made this formula even better. However, if you don't have those all variables available, you can still get along by having the 4 basic variables, which will still give you a calculation, but it won't be as effective. So now coming to the Barrett suite, which has become, I think, the go-to formula for most of us who are using optical biometry really. And the Barrett suite, which also has 3 formulas. For the Barrett's Universal 2 for all the non-toric IOLs, the Barrett's toric formulas, which is basically the Barrett's Universal with the toric calculator, and then the Barrett's 2K. These are the most important basic formulas from the Barrett suite that we use. The Barrett's 2K is basically for all the non-torics after post-laser vision correction, and this again is very, very useful and one of our go-to formulas for post-refractive surgeries eyes. Again, the Barrett suite can also use the posterior corneal astigmatism both as a measured as well as a predicted. But you can use a nomogram which is integrated into the Barrett suite. But as Shreyas was talking about, the TK formula, which is also from Barrett's, that actually uses a measured posterior corneal astigmatism to predict, especially in post-refractive surgery eyes. So the Barrett's Universal 2 is a virgin space formula, and we've already discussed about what all it uses, the A constant and the lens factor, which determines the AC depth, and it's applicable to all kinds of eyes, from the short to the normal and the long type of eyes as well. So the Barrett suite essentially requires at least the axial length, the keratometry, and the lens factor, which is derived from the SRKT factor. And the optionals are the AC depth, the white to white. So if you keep adding these 4 variables, any of these variables, the accuracy of the formula keeps going up. So the good thing is that if you're using a good optical biometer, not only will it take the axial length and the keratometries and the lens factor, which will be obviously fed in, but it will also give accurate AC depth measurements, the white to white measurements, and the lens thickness, and then of course the design factor. So you will get a much more accurate measurement if you're using a good optical biometer which is feeding in all these parameters into the Barrett suite to give you the best outcomes. Now sometimes we would want to use measurements done by ourselves and put it into the Barrett suite online to the Barrett's calculator, but if we don't put all these 7 measurements, we will get a less accurate outcome than we would get if we were feeding all the data into it. So the lens factor is basically calculated out of the SRKT constant. The design factor is specific to each IOL, and we must. So there's a huge problem here. Most of these companies are very casual about providing you the correct design factor, and we've learned the hard way that even the best companies like Alcon and J&J, they will mess up on each IOL has a different design factor which they are supposed to provide you, and it does not automatically come on your optical biometer, and you have to keep checking that you have the updated current design factor for each new lens that you try to use. Otherwise, you'll mess up your calculations. So in fact, it comes as a very fine print under the place where you have the ILPAR prediction using the particular formula. Please watch out for the design factor and the lens factor, whether it is fed in correctly for the particular lens you are using. So the Barrett's toric has again changed completely for our toric calculations, because it gives you, on my IOLMaster 700, I basically get measurements from both the Barrett's K formula for the toric calculation, and I also use the Barrett's TK, which takes the posterior corneal astigmatism into account. So you can use either of the two. And then you also have the Barrett's true K post LVC formula, which basically is based on the Barrett's universal 2. And it, again, I will not go into the depth of how it works, but it is again one of our better formulas for the post-refractive surgeries. I'm going to finish in a minute. So what we actually are now using a lot is the ASCRS calculator for our post-refractive surgery eyes. And you can see here in better detail that it can take in measurements from various things, from your topographer, from your optical biometer, from the OCT, the OptoView gives the posterior corneal astigmatism, and also from the other devices including the pentacam. Once you fed in whatever data you have, so you don't have to feed in everything. If you have just basic data of the axial length and the keratometries, the more data you'll add here, the more chances that you'll have a better outcome. And this is how it gives you a printout. Depending on what all you've fed in, it kind of gives you on different formulas these various calculations. For example, here it's using the Sharma's, the Haggis L, and the Hill pentacam formula, the OCT derived measurement. So it's predicting IOL powers based on this, and then it'll give you a summary of this. It'll give you an average IOL power based on the 4 or 5 different measurements that you fed in, whatever you had, and a minimum and a maximum. Typically in myopic LASIK, you'll end up going for the maximum here, but you have to obviously watch out for each of them in case there's a mistake. So again, from the pentacam, you can derive the EKR report, and that helps in the post-refractive surgery eyes. I think Shreyas has spoken on this total keratometry, so I'll just skip this. But frankly, also if you don't have, for example, a mature cataract and you're doing ultrasonic biometry for the axial length, you can still feed in that data into the Barrett's formula by taking all the other measurements from the optical biometer and just the axial length from the immersion scan, and that can still give you a close to predictable outcome. I think since I'm out of time, I'm going to stop here because we've discussed. The only thing probably which I wanted to add in a moment is the Super Ladder's formula, which uses many of these formulas from almost 100,000 surgeries. So it's an ever-growing formula. It's also artificial intelligence based, and there are some inputs from Uday Devgan to this, among other people. And the two formulas which need mention are the Kane formula, which I really use for post-keratoconic eyes. Again, among the very good formulas today. In fact, this has become part of the ESCRS IOL calculator, which I also use quite often now because it has all the latest IOL databases available to it. It's a free formula for ESCRS members. And the EVO formula. These are the two very new, very predictable formulas in addition to the Barrett's. So it would have been incomplete for me to miss it. And I'll close with the ray tracing calculations, which are now possible with the Oculix software. These can be again done freely online by feeding data from several devices, including the pentacam and the Anterion and others. So I use this on the Anterion. So I'll stop with that. These are the applications from the ray tracing. Thank you so much.